Good morning, everyone, and we're going to go ahead and get started. Thank you, Jenny Johnson, for putting Bacon County in that you're there. If y'all don't mind, over in the chat, just put who's on this morning and the hospital that you're located in today. So our agenda is very similar to every month. Right now, we're in the ending stages of this cycle that we're in. So we know that we're going to be going to safe use of opioids starting in September. And so far, so good. I do have one speaker lined up. An outside company will be talking with us to kind of kick us off in September. So looking forward to getting that started. Today's events, the main thing is the showcasing of two hospitals that have been so willing to share with us. So I'm going to move on because one of the hospitals does have an engagement. They're having some activities in their hospital this morning. So I'm going to move on a little quicker through this today. And we're going to start with Rebecca Bishop, the Chief Quality Officer from Warm Springs Medical Center. And Rebecca, at this time, you can tell us a little bit about what's going on in your hospital today, but also share your story of all the great work that you all have done. So Rebecca, the floor is yours.
Good morning. Just making sure you can hear me okay.
We can. Thank you.
Okay. Thank you for allowing me to go first this morning. We're actually having our National Nursing Home and Hospital Week. It had to be rescheduled. We normally hold that in May, but just due to some scheduling conflicts, they had to reschedule that. So as of right now is our 50s day. We have a car show outside in the front of the hospital. We're dressed in our 50s. We're having some people come and sing, and then we're having a sock hop and ice cream in the lobby later this afternoon. So all this week, we're having a lot of activities. Our volunteer coordinator, business development team just do a really good job about recognizing our staff. So we have a big week planned. So I appreciate you letting me go so I can help the team with those things.
Great.
My
Sounds
name
like
is Yeah, it's a fun time. It's a fun time. But my name's Rebecca Bishop. I'm kind of the new kid on the block. I just started in this role at Warm Springs this past November. So I've been here just about 8 months. Learned a lot. I had quality experience, but it was mostly in home health and hospice. So definitely a different environment and atmosphere. I had to learn just the rules and regulations. But I love quality. So that piece, doesn't go away. But I'm still learning every day. And I just love it. I love to be a part of this team and be able to share what we're doing at Warm Springs. I'm also not from the area. I'm about 45 minutes away. So there was a lot I had to learn about the community coming into this role. So Warm Springs Medical Center was established in 1957. We're a 25-bed critical access hospital. We are located in Warm Springs, Georgia. Our biggest county, our county head or seat is Meriwether County. We provide 24/7 ER services, diagnostic imaging, lab services, rehab, and therapy. And the majority of our patients are swing bed. We have a swing bed program here. And I'm going to try to find that link mail. One of the ladies that is really involved in the business development part of that, she said that we have a good link explaining that. So I was going to send that out as soon as she gets that to me. I didn't have that for the presentation. But in September of 2023, we partnered with RPG, which is Rural Physicians Group, and we launched a hospitalist program, which makes sure that we have a hospitalist in-house 24/7 to make sure that we have coverage. And they serve on the med-surg floor as well as communicating with the ER docs if we admit anyone to the floor. They also will help cover the nursing home as well. You can go to the next.
Okay.
So just some fun facts. I like to, when I'm presenting, give a little history about where we are and some fun things about us. We were named after our warm springs here, and the temperature in those springs ranges about 88 degrees on average, and they believe to have therapeutic properties. Actually, Franklin Delano Roosevelt visited here in 1924, and he was seeking treatment for his polio. He built a home here, and they call that the Little White House. There's a picture of that on the slide. He also died here in 1945, and it's a major historic site. We have a lot of history buffs and tourists that come annually to view the home. There's a museum there, and some of the people here, I have never been, I need to go, but they said in the museum it's pretty much preserved from the day he passed away, so that's pretty neat. We are often confused with Roosevelt Warm Springs, which he founded that in 27, and that's right down the road from us, and that was to treat the polio patients. It also has rehab services, but that's more of not a swing bed, but they participate in therapy from like the time they get up to the time they go to bed. It's really aggressive therapy. So we are so close in proximity. There is some confusion about us too. We have less than 500 residents. It's a quiet town. We have a lot of quaint shops and cafes, and it's a walkable historic district. Can walk from my office downtown to get lunch and walk back, so it's pretty nice. And then we are located near one of Georgia's largest state parks. There's hiking, camping, fishing, and wildlife, and that's FDR State Park. So our action plan, when I came in, Danny I was helping train me, and I got a lot of this information. They had already started on this before I started here. But the action plan for Warm Springs, we were to identify the top 2 disparities using our social determinants of health, and then also provide resources for that population that's screen positive. And then we want to also identify and review readmissions for any trends and interventions. So Danny had already done the first one, but he had to coordinate with our vendor, which was CPSI. That's our EHR. And it is a smaller program for some of y'all that use it. So we kind of just had to tell them what we needed to be able to capture that data. So we have a tool that's embedded. Our admission nurses complete this data so that we can identify the disparities once the patient comes in. And then we also, as far as I know, there may be something, and I was listening to some of the other presentations. I'm going to look into that about running reports to identify those, but we keep a spreadsheet that is able to be filtered by race, ethnicity, male or female, and then just the different disparities so that we can look at that easily and kind of get the data from that. So we just use a spreadsheet of anybody that was positive. We keep that on there. We're communicating with our social worker. And it's just a tool that Danny had started, and I just kept it going just for ease of use to identify those. So that is completed. And then we do, since we are kind of, I mean, everybody's rural, but we have a lot of agency use here. So just educating and training the staff to making sure that they're doing this. I noted after I had been here a couple of months, in January, we have a scorecard here that we keep up with our different goals. And since the healthcare equity and social determinants of health is a big thing that we're looking at here, we added that to our scorecard. And we had noticed when I was doing the audits that we were missing some of those. And we don't want to miss the people because we want to give them what they need, and making sure that they have the tools to be successful when they go home or if they're needing placement. But we were at 46% in January. So we identified some issues with some agency staff. One, not knowing what the determinants of health was, or just 2, just not completing it and it getting missed. So we have a lot of education and training for the current staff. And then we're making sure as these new people come in during their orientation that they are educated on that, to making sure that those are completed. We've put processes in place for the nursing supervisors at each shift so that those are not getting missed. So that, because that's very important for us to make sure that we can identify these needs and so the patients are taken care of.
And Rebecca, I'm going to stop right here for just a second, if you don't mind, and ask on your behalf if there are any other CPSI users on today, and you have found some tricks of the trade that might help Rebecca out. If you could just put CPSI and drop your name and email or contact information over in the chat. Maybe the 2 of you, or 3 or 4, how many ever is on today that's figured this out, maybe they can help you out a little bit, Rebecca, at least to put you in a direction. So, again, Shannon, I see that you said you're CPSI. So if you don't mind sharing your contact information so that you and Rebecca can have a conversation. And now I'll move us on. Rebecca, thank you. And Melissa, thank y'all.
So as I said before, we had created a spreadsheet to identify the positive responses to the disparities. We refer those to our social worker, case manager. That's one and the same here. We also discuss at monthly meetings, but we also talk about this. We have IDT meeting every day just to go over the patients. It's just a quick synopsis of what's going on with the patients, any changes in condition. But I identify then if there's any missing so that we can get those done. And then we talk about any of the disparities that might affect their care while we're here. And so the nurse is in there, the nursing supervisor, as well as the case manager and the different departments. So we talk about those every single day. And like I said, it easily tracks and filters the patients. We did identify that transportation was an issue, but it did not discriminate here. It was equal in almost every category. And then our second disparity, I'll get to that in a minute, but we did identify that Black males reported the most food insecurities. But as far as transportation, there was really it was equal across the board. So one of the action plans before I got here with the previous social worker and our CEO, they had applied for a state grant to provide 2 vans for underserved population, but that was denied. So they didn't get that. So there's talks right now of trying to work on a partnership with Glory Brothers Transportation, maybe getting a contract, because we utilize them a lot for our transportation services, just to cut down the cost. But then another option is we do have an activities director here. She would have to be CPR certified. And then we also have a nursing home van that they use because we have a nursing home that's attached to our facility. A nursing home van that they use that we could also use as well for our transportation, but that's something that's just in the works. They're just looking at cost that has to be approved by the CEO. But we're just trying to think outside of the box because the transportation is limited and we can give them resources, but I think everybody in the state is dealing with transportation being an issue. So I've been trying to listen to, all the other presentations to try to get ideas on that, but that's just where we are here, that was our number one disparity. We're also working with Merriweather Family Connections. Our food disparities was identified as our number 2 positive screening, again, specifically in our Black males. Merriweather Family Connections hosts food classes for families, and we didn't know that when we had our CHIN meeting. We figured that out. Like I said, I had to learn a lot about the community. I'm not from here. But they are sharing those dates with us, and we're posting them on our Facebook page, and then we're also sharing those with the patients here that are expressing those needs to try to get them involved. Also in our community, we've learned that our churches are very involved in offering assistance, and when we get to the last slide, you'll be able to see that I shared our resources page. But we have a lot of food banks, a lot of pantries that the churches have. So that's something that we also share with the patients that report these food disparities when they come in. We also have, there's a local restaurant here that has a fruit and vegetable stand. And if I have connections with this, she's a therapist and we've worked together for a while. So if we ever have a family or patient in need, she is real good about donating things. So we have her as well as a resource. Drive-through events, they do host, Merriweather Family Connections also hosts drive-through events, kind of like a mobile pantry. So they give us those dates as well. And we share those with the patients and post those again on our Facebook page. And then we have a big screen out here in the lobby. So we try to post those as well so the patients and families can see those. All right, so we also wanted to track and identify our 30-day readmissions. This is an ongoing process. Prior to me coming into this role, the social worker was tracking this data and sharing it, but now I'm pulling it. And we do have, you'll see on the next few slides, we have a relatively low readmission rate. But I'm continuing to monitor these disparities as well as cross-reference into the readmissions to see if there's any trends or we can implement any actions as needed. We just want to make sure that the patient has safe DC plans, realistic expectations. And I will say that we have I'll talk about it in the next slides, but there are a lot of social admissions here to the hospital. And we just have to educate the doctors and social worker and making sure the staff is communicating with us and we're identifying these disparities so that we can have appropriate discharge plans for these patients. Okay, so on our data analysis for 2024 and 2025, you can see that our transportation screen positive was 46%, so that's the number 1. And then our food insecurities at 24%. Utilities and housing was right below that at 21%, and then safety at 9%. And then we do have resources we get to later that addresses all of those, but our top 2 were transportation and food insecurities. And then when we screened by race, 52% white and 46% Black. And then we had, I think, just one response that was other here. It's broken down by race. For our readmissions, our 2024 is in the blue, so you can see that was pretty high around September or October. And then as of this year, that has come down. So I feel like with people, we're starting to look at those readmissions. And like I said, the education with the doctor, social worker, and our staff to bring those needs to our attention, just making sure that we have appropriate discharge plans and those people are not returning to the hospital. And you can see the 2025 data is a lot less than 2024, but we're continuing to track it just to see where we are. I also looked at readmissions by sex. 64% of those were male. Again, 61% white, 36% black, and the 3% was other. But the big thing for us, which is interesting, but I do want to start out by saying when we looked at our China, our community needs health assessment, 2 out of 5 residents in Meriwether County are 65 plus years or older. And then they reported between 2017 and 2022, there was an increase of 5% in our elderly population. So that is reflected. You can see that in our readmissions by age. Our biggest category was 60 to 79-year-olds, followed by 80 to 90. So we have a huge elderly population here in Warm Springs. So I also did the readmissions by category, and as you can see, what stands out is the other. So I looked at those, and as I just said, that kind of ties to that. We have a lot of elderly patients, retired residents here in Warm Springs that really just want to be independent. So when I looked at those others, those are things like dehydration, altered mental status, failure to thrive, and that's not shocking to me. We always have patients that are, we think that they might need assisted living, but they want to try, 24-hour caregivers at home to see if that works. So we do have a lot that come back and, we've educated them on what we think the discharge plan is for them. And it's just so hard for them to, give up their independence. So we try to make sure that we get all the resources for them to go home and try it, but it's not always in our eyes, the most safest, but we do try to give them all the resources that they have and try to prevent those. We do have wounds was kind of the next one, but we do have an infectious disease and wound doctor here that follows patients when they leave. So if for some reason maybe they're set up with home health or something, and then they start to have issues, he will bring those back in. So that's just why we have a lot more wound patients at readmitting to our facility. And then respiratory is not shocking. That's usually one of the high ones. And then the rest of them are pretty much even across the board. But just to explain the other, it's mostly what we see in the elderly population, the dehydration, altered mental status, and failure to thrive. And so this is the resources. We don't have a pretty little pamphlet or anything, but we do just have this printed out for anyone that states that they're having food disparities or transportation. I just took this directly from what we give them. But there, as you can see, like I said, the churches, you can see there's several churches on here, and it tells them exactly what day of the month and what the times are. And also we have their contact information. So if it's an urgent need, we can call them and we can get pretty much the assistance that we need quicker, whether it's, a volunteer coordinator going over to get it or just coordinating a time for the family to meet with them. They are really involved in making sure that these patients get what they need. There's also a couple of food banks. I did include the emergency food and shelter program just because we don't have a ton of them, but utilities and housing is one of the other disparities that was kind of third on the list. So we also give them information about that. And then transportation resources. A lot of them don't know about the Three Rivers Transit. You do have to schedule a trip, so that's an issue for some. And then the cost is $3 for Meriwether County, and then it tells their hours of operation. We do give them that information. A lot of them is just not having that knowledge and not knowing. So we do give them this information. Again, we do have churches that are very involved. So we do have volunteers for them that if they're just needing, it's an elderly person and they're just needing a trip to the doctor, they just can't get it. They don't have any family here and they don't have a way and it's not safe for them to drive. We have contacts that we can utilize to try to help get them to that. And we also, it wasn't on the slide, but we have a rural health clinic that is a part of Warm Springs. So if they don't have a primary care, we try to set them up with our providers there because it's local and it's kind of easy to get to. And then we use the same system, so their information is in both of our systems, so that makes it easy to kind of follow the patient. So we also do that just to try to help them with their healthcare needs as well. But this is just something that we give them if they report any of those issues. I go over it with them, and also the social worker, just to make sure that, like I said, we have safe discharge plans and that they feel like they have the resources that they need before they leave the hospital.
Thank you, Rebecca. And I believe this is your last slide, I believe.
I think so.
So I want to say congratulations, because I think all of us remember whenever you came on board in, I think you said February. Is that right?
No, November.
November. Okay, November.
Yeah.
And I think Danny left you thereafter. Danny had been active on some of the work groups that we had done last year and before. So I think you've done a wonderful job. And even though you're not currently living right there in the area, it seems like that you've really done a great job of bringing and helping to bring resources together. And I know that in Warm Springs, I have visited there before. So that's the great thing about all of you presenting throughout the state. You have a lot of opportunity. You also have a lot of opportunity for folks coming in, not only at your state park, but there around the fall of the year. I think you have an increase in foot traffic around the whole area, if I have that right. But anyway, we thank you for everything. And I noticed that some of the comments that we've seen with sharing of the resources and everything that you all are doing from that standpoint, I think that this just is a good idea. And I'm really happy to see that a lot of you are being able to find those food insecure resources through the faith-based organizations. Sometimes you just don't know what's going on until you really get out there and start digging. And I think, Rebecca, you probably could say that that is a true statement.
Yes, ma'am.
For you coming into everything. Does anyone have any questions or comments or thoughts for Rebecca right now? I did see a couple of CPSI users, Rebecca, over in the chat, if you'll grab those, that share that they also have CPSI. So maybe that will help you out a little bit. But any other thoughts, comments, or you can take yourselves off mute or drop something in chat if you would like. Karen and Hannah, I can't see chat, so if you all could tell me if anything comes through.
Yes, we do have a comment from Kelly Smith. Elbert had to contract with an ambulance service to take care of our transportation issues. It's very expensive, but we had no choice.
So they're again an alternative, but I know in the rural areas, expense is a barrier and a factor. Anything else, Karen?
That's it.
Well, Rebecca, I do wish you had sent us a couple of pictures of the 50 sock hop and everything. It sounds like y'all got a lot going on in the hospital grounds and on around today. So we thank you for joining us, and hopefully y'all will have a good day, good weather, and everybody can celebrate.
Thank you so much. I'll send you some pictures.
All right. Thank you. When you send them, I will share with everybody.
Sounds good. Thank you so much.
Thank you. All right. We will move on. Tammy Stone is with us from South Georgia Medical Center Health Lanier Campus. So Tammy, if you will go ahead.
Okay. Can you hear me?
We can. Yes. Thank you.
Okay. My name's Tammy Stone. Lanier Campus is actually part of SGMC in Valdosta. It's a big system. The Lanier Campus is our critical access hospital. And we also have an acute care facility in Nashville, our Berrien campus. So our quality staff actually takes care of both of those campuses. And this next slide is just going to tell you a little bit about Lakeland and the services that we offer. I will tell you between the two campuses, Jennifer, who's online, she's our quality manager, we stay extremely busy. We just opened a new emergency department at our Berrien campus. And over at Lanier, we just got finished up last week with our DNV 3-year reaccreditation. So we did very well with
Congratulations.
it. Well, thank you. But we've just been really busy and just being as transparent as possible. Jennifer and I probably have not been involved with this project. We got involved with this project probably around the 1st of 2025. They had already built the part in Epic to get the data extracted for us. And after we felt like that we should be getting some data, we kind of started looking at it and realized that there was a glitch. So, and the processes are different in our system with the smaller campuses. The Epic build was built for case managers and social workers to be able to put that data in. But what was happening at our campuses, nursing service was the ones that was designated to gather that data. So there was nowhere for them there was not a place built for them to put that data. So we had a few hiccups right there to begin with, figured out what was going on, and finally got the builds that we needed and the staff trained. So as you'll see from the next slide, I didn't go through all that, with each step that we took. The project leader was our campus administrator, and just focusing on one goal, he felt the need for transportation services. I know, Melody, you know Jeff, and he's part of the State Office of Rural Health, and he goes to a lot of these meetings in the community, and we have a very active advisory council, so he gets a lot of input from the community. So he felt like before we ever collected any data, that transportation was an issue for our community and surrounding communities. So he wanted us to analyze opportunities for transportation services as rural communities often face unique challenges due to sparse population density, limited infrastructure, and geographic barriers. So that's kind of what we'll focus on today with the next slide.
Okay.
So I left out the action step about Epic because that could take days to explain all that that went on with that. But we do have our nursing staff and social workers assume the responsibility of getting the patient information gathering. And we felt like that, after the first month, we were like at 44%. Thank goodness we have a great nurse manager at Lanier, and she said about doing a lot of education. And when she went about explaining the importance of what we were doing with the data collection, I think that played a big part in getting it compliant. So I just looked at June data. So as far as all of our patients being queried, May was 100% and June was 100% as well. So big strides made in that because it was a new process for nursing service and social workers to adapt to. So although this data collection is new and we don't have much of it, we can already tell that the data collection kind of validated what we were doing to begin with. What we identified we wanted to work on is transportation. We haven't had any indicators trigger positive, food, none of the housing. The only thing that we've had trigger is transportation. So I think this whole thing has been important. You're able to show the community leaders, look, we know we've identified the need for transportation, but we want to show you with this data what we found. So I think that's a good part of this whole project. And Jennifer, she lives in Lanier, so she has a good idea. I don't think the food disparity is showing up there simply because there are a lot of resources at there, and she might want to speak to that. But there's like he was talking about the church, the food banks, and things like that. There's a lot of resources with that. So what we've done so far is just investigate, kind of look at opportunities that we have right now. And I didn't print a list of all, I talked to the social worker, of all the list of resources that she's got. But, so this Southern Regional Commission, now this is nothing new, but what Jeff has found is, introducing this to the community leaders, it's being utilized more. Just giving them the information, Logisticare and other companies like that. I mean, I know it's been around probably since the early 2020 maybe, but as far as for Lanier, it's just being utilized. And then there's also, I'm sure y'all aware of the Medicare transportation. If you qualify, if you're Medicare and Medicaid recipients. We're also looking at, as far as the community, we're working on, public transportation for them and transit for them. But also, our nursing home is right there, beside our facility. And we wanted to look at providing transport to non-emergent appointments, that and our swing bed patients. And, I think it was Jeff that actually came up with the idea of raising money for a new van. We have one, but we needed a new one. So he's actually selling tickets and getting help from our local foundation to fund, the use to get the new vehicle purchased. So overall, I think that we've done some. We're going to do a lot more. But just from the time that I've been involved with this project, we've come a long way just getting the data abstracted. It's just been a bumpy road for us to begin with.
And so, Tammy, you mentioned you all have Epic, which is, I'll just say, it seems, a much larger vendor than some of the others. So, smaller is great. It may have its limitations, but then I think what you've described too is, even though you have a larger and you're, part of the larger system and everything, sometimes there are hiccups along the road with that as well.
Well, what we found, being part of a system, we've been a part of a system. I think Berrien in 2013, and then Lanier right after that in 2014. You learn by doing things a lot of times. I mean, and a lot of it's got to do with communication. Their needs are different than our needs. Our staff have different roles and responsibilities than their staff. So I think if this taught us anything, it's data gathering, collection, and reporting. You're going to have to find all the people needs to be on the table. Sitting around the table discussing what we're going to need and who's going to get it and how it's going to be reported. I mean, it's all worked out now and it comes up in a beautiful report and it's demonstrating what we thought we had a problem with. But I think it would have been a lot easier on Jennifer and I had we been included in the beginning, so.
So lessons learned for future opportunities. There is another thing that you have in here under 2B down here. Hopefully everyone is aware of votive care. I don't know if I said that right or not, but can you just speak to that 1 minute or a second, however, how you utilize that, just to make sure that everybody on the call today is aware that you can use that. If you know, and I know that I know you're kind of pitch hitting.
I spoke to Jeff just briefly about these. He knows more about this than I do. I really know more about the Southern Regional Commission because it has Logisticare and things like that. And I know about that because my sister used to work for him. But as far as this transportation, I might have it written down what he told me about it, but.
Okay. Well, anyway, that's just something for folks to explore. So just maybe another option out there that some are maybe not utilizing. And that's the good thing about everybody presenting like you all are doing. We get to learn from each other and learn how each other, so we've moved from West Georgia down to the very southern part of the state today, but we have pretty much covered all of Georgia and will continue. So Tammy, anything else you want to add? Because I think this was your last live this morning, I believe.
Yes.
Any questions or comments for Tammy, or if anyone has used that mode of care? If y'all want to put any comments or come off mute and tell us how that went for you.
We've used it here a couple of times at Monroe County Hospital for patients who typically have Medicaid. We've used it even to get them home, to discharge home. We've used it a couple of times, but there are some limitations. Like if you have a follow-up appointment, you have to call like 3 days prior to the appointment to schedule it. But at discharge, if it's a discharge transport, then you can call it discharge and they'll make arrangements. But we've used it a couple times.
Okay. All right. So if others haven't, that might be something that you could look into in your areas. And Hannah or Karen, are there any comments or questions for Tammy in the chat box?
No questions, Mel.
All right. Well, Tammy, thank you for presenting this morning. And I think if nothing else, a lot of you have nursing homes either attached or on the campus. Love the picture of the campus that you showed just a few minutes ago, Tammy. And so, sometimes that is a challenge of how you're actually working across for both the hospital and the nursing home. But sometimes it does bring everything together to really focus on the needs of folks, especially for those of you that have nursing homes and have short stay residents that are discharging out in the community as well. And you're trying to look at ways to avoid those readmissions. And so I think that both of you did a great job this morning of bringing all of the work that you've done. And we thank you for presenting it. It's always better for us to hear from what all you are doing, because again, learning from each other. And again, this mode of care, I'll move on from the slides, but just make sure to, kind of note that if you're not using it, that might be something that you look into for the near future. So we will move on. I put a few things in here. I think they primarily are around physician practices, but some of you I remember Rebecca mentioning that they had a clinic. Some of you have clinics or other areas of physician practices that come under your umbrellas as well. So whenever you go out, and the slides are available, I know that Karen and Hannah have dropped the links in there. This particular one is for tomorrow. It might not be for you, but someone in your organization. So if you want to share that on, that is always, you're always welcome to do that. And then I did put some physician payment information in here. Again, for those of you that actually have physician practices under your umbrella, some of this might be pertinent. I noticed the fee schedules and payment programs and things like that. I thought that might be interesting for you to either have or share. I have had this in for a few months, just wanting to always bring, to your attention the social drivers of health and screening positives. I think you all are doing a great job, as your presentations have shown us that this has been a learning opportunity. Tammy, I like what you said. Jeff had an idea right out of the gate of what y'all were going to focus on, and it so happened that did fan out in your data to show that was an area of opportunity. I know some of you have reported that what you thought was not exactly what your data showed. So just, keeping that on your minds. And then again, in September, we will be moving over to the safe use of opioids. And so, sharing the slide, just trying to get in your minds around what your descriptions are for the measures, the rationale. And again, in the rationale, I think, knowing the unintentional opioid overdose fatalities, it is considered at epidemic proportions now. And then I want to go to the actual numerators and denominators. And so if you are, haven't already looked at these for your hospital, now would probably be the time. Probably some of you put this into place already. And you may not have any. And one thing that we know, your denominators may not be that high. But again, I do want to draw your attention to exclusions. I know we had several conversations around social determinants of health and who was included and who was excluded. And so, just really taking this and looking at your exclusions and what will not count in your denominator factors. So, giving this here for your opportunity to wrap your head around what's going on in the hospital before we get started in September. Again, I think Dawn might still be on with the State Office of Rural Health. I have aligned a speaker that I think that all of you are going to appreciate for the September kickoff meeting. They're doing some work with critical access hospitals in the state. And so stay tuned for more. We'll have that announcement. I meet with them one more time just to firm everything up. But I was trying to align someone that I knew would provide some services that you all need, especially those of you that are Joint Commission accredited. And so we will see make sure that that's going to be firmed up next month for September. Now I do have a question for you all, and you can either come off mute, or if you don't want to, if you will please put your responses in chat. And I want to camp here for just a minute. In order to be able to bring you the best program that we possibly can, I need to know what are your as far as safe use of opioids is concerned, what are your current challenges, barriers, or needs? And also, what do you feel would be the most beneficial way or means to assist with the measure for safe use of opioids? So if you all could please think about that, put your answers in chat. If you are not real sure, if maybe you're not the one that is primarily working on this right now in your hospital, if you could take this slide and just in your quality or meetings that you all have, if you all could please see if you could get some answers to this so that will help me align the future presentations that we have, and maybe even again go out and align some speakers to help with this, because you have all said that this is an area. I've gotten several comments back from you all that this is an area that you really need some help with, but I need to know, what do you need? So again, what are your challenges, your barriers, your needs, and then the most beneficial way to bring information to you would be great for me to know. And Dawn, as well, as we set these programs up, and again, we're very thankful for the State Office of Rural Health in Georgia. I think we have the best, and we know we have the best staff working there to help us all out. So I can't see Hannah or Karen if anybody's dropping anything in the chat. And again, from chat, if you don't want to put it in there, just send me a private message, after today, and let's see what we can do to put everything together to align resources and things that you will need. So
nothing in chat, Mel.
Okay, so I've left these slides in as well for just some data analysis components. This is, we're kind of wrapping this up as we go forward. Looking at the different ways that you all have collected data. Y'all have done a great job. We probably will use something similar to this with your safe use of opioids and getting to know how you collect data and how you're looking at your data. Because the data, again, will tell the story. I believe that if you will take the same concepts that you have used for, as we began with health equity, and then we moved over to social determinants of health. But if you will take that same modality, that same thought process of looking for trends in your data, let it tell the story for you of, who your patients are, where they're coming from. And, even with them, I think you may be able now to apply some of the learned lessons that you have from your social determinants of health, because they may fall into some of those categories that they need help, outside. And I don't know that, again, until, we begin to look at data and we begin to think about what you all have and what you all are seeing, that we will know exactly where we're going and what you all are dealing with. You may have a handle on it already. If not, I would say that, this is the time to really think about it and think about what this means in your hospital and looking at those numerators, denominators, and those exclusions very closely. If you need some one-on-one technical assistance with that and with just looking or brainstorming, please feel free to call me. at any time. And this slide probably should have been up at the front because we've already had our sharing. I do want to say that we already have, I believe, 3 hospitals to report out in August. But if some of you that have not reported want your story included, by all means, please let me know. And I will be more than happy to accommodate. We may go a little bit over if we have more than 3 hospitals or 4, or how many ever. But this is your time to shine as we end up. And this will be your time to really tell your story and be able to share with others. Right now we have Will's Bacon and Liberty was added yesterday that we'll be sharing in August. But again, if any of you on today would like to share, and Jenny Johnson, I can send the PowerPoint template to you all after the call today. I'll make sure that you have that. And so, as you see, we are wrapping up. August, we'll wrap up the social determinants of health. We'll have discussions and overview those final action plans for those that share. And then we'll be preparing for the next phase for safe use of opioids. I've had a couple of questions. We're going to stay on the same cadence to meet the last Tuesday of the month at 10 a.m. That seems to have worked out fairly well for a good time. I've had a couple that have conflicting meetings, but luckily they've been able to have someone to attend in their place. But anyway, we will stay on the same cadence unless there are a lot of barriers or, something that comes into place that we would have to change. But otherwise, just go ahead and mark your calendars off. And I think that Hannah and Karen, we're so glad to have them supporting us in the background. I think that probably will soon have all of the links for you to go ahead and register for those, just as you have done in the past for the ones that we're working on now. We do have our website still up, and you can go. We have more resources out there now for the safe use of opioids. But please feel free. All of the presentations have been loaded, and even the one today is already uploaded out there. You can go and use that for any resources that you need. In addition to that, when you go to our site, if you drop the flex off here and just put allianthealth.org, for some of you that might need some ESRD or end-stage renal disease resources, you can also find those out on our site as well, as we support one ESRD network. So those are out there. I left these resources in your ARKITA, I think is what you all call it, the Rural Quality Improvement Technical Assistance Resource, as well as your Rural Health Hub and Research Gateway, where you may be able to find some information. You may also be able to find some information out there now around safe use of opioids that would be very prudent and necessary for you to start looking at. And so I'll leave it to questions. Plus, I think, Karen, you want to go back in and give some update on the continuing education this morning.
Yes, for anybody that would like to obtain a certificate for joining today and some CE, so continuing education credit, we have a link in chat that will take you to a brief survey or evaluation that's necessary to receive the certificate. So Hannah just put that into chat. We also did have a question, Mel, about the PowerPoint template, the location of that PowerPoint template.
Yeah, and I will send that back out. I'll also try to remember to send it out with the post-event email that you all get. But I think that came from Jenny Jones, and I will send that to you just in a few minutes, Jenny. All right. Well, again, we want to thank our speakers today. Rebecca may have already dropped off. Tammy, thank you so much for staying with us. We do understand that you all have celebrations and a lot of activities going on with your hospitals, and those of you that have nursing homes, that as well. I think that you all do a great job of updating the community. I think that some of the information that you have out there, especially around the activities that the community can be involved in, is prudent to the rural areas that we all work and live in. And I can say that because I do live in a very rural area as well. So I thank you for everything that you all have done. Look forward to August and the presentations that we will have there. This has been a great opportunity at the very end here for you all to share with each other. I do think the couple of you that put the resource in that you have CPSI. That's a great opportunity for peer-to-peer sharing and you all helping each other out as we go through and we just make Georgia better. And so thank you again to Dawn. I'm not sure if she had to drop off yet, but Dawn and Amanda at the State Office of Rural Health for making these events possible. So with that being said, you all stay cool. Enjoy the rest of July. And as we get into August, good luck with going back to school and everything that we have a buzz around that. But until August, thank you. And we will see you next month.